Welcome to the Deep Dive. We're the show that helps you cut through all the noise and really get to the essential insights you need to be genuinely informed. There's just so much information out there, especially with critical health stuff. How do you grab the life-saving knowledge quickly without getting totally buried? Well, that's what we're tackling today. We're doing a deep dive into something really vital, acute coronary syndrome, or ACS. Now, you probably hear heart attack and you think, okay, one thing. But what our sources are showing us is, well, it's more like a spectrum, a really crucial range of urgent heart conditions. We've gone through detailed medical info, clinical guidelines, and pulled out the most important bits for you.
Yeah, exactly. And our mission here is really to demystify ACS for you, our listener. We want you to understand the different types, how doctors figure out what's happening, and those critical immediate treatments. And, along the way, we'll uncover some, frankly, surprising differences and useful takeaways that might just shift how you view these conditions.
Okay, so we all say heart attack, but the sources point straight to this idea of acute coronary syndrome, ACS, as a wider spectrum. What's the main takeaway from that? How does thinking of it as a spectrum change things?
Well, it's key because ACS really covers this range of urgent heart issues,
Mhm.
and they all fundamentally come down to an acute problem with blood flow getting to the heart muscle itself. Usually, this starts with something called plaque rupture. You can kind of picture it like a little tear inside a heart artery's lining. That tear triggers a clot, and that clot starts blocking the blood flow. Now, depending on how much it's blocked, and crucially, whether heart muscle actually dies from lack of oxygen, we get the three main types: unstable angina, instability, and STEMI.
Right. Okay, let's break those down then. Starting with unstable angina, or UA. What makes that one distinct?
Okay, so unstable angina, UA. This means you're having symptoms like chest pain that really make doctors think heart problem. But here's the critical bit. When they check those specific blood proteins, the cardiac biomarkers like troponin, they're negative. That tells us, importantly, no heart muscle cells have actually died yet. Now, you might see some worrying signs on the ECG, maybe ST segment depression, things like that. But the main point is the artery is seriously narrowed, causing symptoms, but it's not totally blocked, and there's no permanent damage yet. The pain itself is usually different. Maybe it's new, getting worse fast, or happening when you're just sitting still. And it doesn't get better with rest or the usual nitroglycerin pill.
Okay, so UA is like a major warning flare, but the heart muscle's okay for now. What happens when we step up to NSTEMI? What's the shift?
Exactly. If UA is the warning flare, NSTEMI, that's non-ST elevation myocardial infarction, means unfortunately some actual damage has started. You still have those symptoms suggesting ischemia, the lack of blood flow, but now those cardiac biomarkers, troponin especially, they come back positive. That confirms heart muscle cells have been injured or have died. On the ECG, you'll still likely see signs of ischemia, like that ST depression maybe, but crucially, you don't see the big ST elevations that scream total blockage. The underlying cause is still that plaque rupture and clot leading to severe narrowing, but this time with some actual heart muscle injury.
And then we get to the most urgent one, the one maybe most people picture as the classic heart attack STEMI.
That's the one. STEMI, ST elevation myocardial infarction. Again, you have the ischemic symptoms, you have the positive cardiac biomarkers confirming cell death, but what really sets STEMI apart is what you see on the ECG. Significant ST elevations. These big upward shifts in the electrical tracing mean there's a total blockage of the artery. It's completely occluded. And it's also really vital for you to know this. If someone comes in with acute heart attack symptoms and their ECG shows a new left bundle branch block, or LBBB, that's considered a STEMI equivalent. It gets treated with exactly the same urgency as a STEMI because it signals that same level of critical, complete blockage.
It's pretty amazing how those, subtle wiggles on a line or a number in a blood test points to such different situations.
Yeah.
But let's back up what actually causes these things to happen, and how does your body try to alert you that something's gone really wrong?
Right, connecting it back. The overwhelming cause for most MIs, most heart attacks, is atherosclerosis. That's the buildup of fatty plaques inside your arteries over time. The immediate trigger is usually that plaque rupture. We talked about a small tear. This sets off a chain reaction. Platelets, tiny blood cells rush in, stick together, form a clot, and boom, that clot blocks the artery either partially or, in the worst case, completely.
So plaque rupture is the usual suspect.
It's the most common, yeah. But less often, heart attacks can happen for other reasons. Things like inflammation of the blood vessel walls, that's vasculitis, or maybe a blood clot travels from somewhere else and lodges in a heart artery and embolism. Another cause is coronary artery vasospasm. That's where the artery itself suddenly clamps down, constricts. You see this sometimes with cocaine use, what we call a cocaine-induced MI, or in a specific condition known as variant or Prinzmetal angina.
Okay, so those are the underlying mechanics. What about the warning signs? What should people be listening for, when their body's trying to send an SOS?
The absolute classic symptom is chest pain, but it's often described less as pain and more as a pressure, a squeezing, or tightness, usually right behind the breastbone retrosternal. A key feature is that it typically lasts longer than, say, 20 or 30 minutes. And importantly, it doesn't get better if you just sit down and rest, or even if you take your usual nitroglycerin. And that pain, it can radiate to some surprising places. Your lower jaw, even your teeth sometimes. Down the left arm is common, but also into the upper abdomen, the epigastrium, or even into your back or between your shoulder blades. And here's a detail from the sources that's quite striking. If you're having that chest pain, even while you're completely at rest, that often signals a really severe blockage, frequently over 90% of the artery.
Wow, 90%.
Yeah. And beyond the pain, your body often kicks into its fight or flight mode, that sympathetic nervous system response. So you might feel intense anxiety, break out in a cold sweat, notice your heart racing or pounding, feel nauseous, maybe even vomit, or feel dizzy and lightheaded.
And I've definitely heard about silent MIs. That just sounds terrifying. What exactly are those, and why is it so important for listeners to know about them?
It's incredibly important and maybe something you haven't considered fully. About a quarter, maybe even more, of heart attacks are what we call atypical or silent. And this is especially true for certain groups: women, older adults, people with diabetes, and those who are obese. Instead of that classic crushing chest pain, they might just feel discomfort in their abdomen, maybe some jaw pain, or just suddenly become very short of breath, often without any chest pain at all. And it's so crucial for you, the listener, to be aware of this, because someone experiencing these atypical symptoms might not realize they're having a heart attack. And that delay in seeking help can tragically make all the difference in outcome. Knowing these variations could literally save a life.
That really is eye-opening. Okay, so someone comes into the ER with symptoms, whether typical or atypical. It sounds like an absolute race against the clock. What's the detective work doctors do? How do they diagnose ACS so fast?
You're right, time is absolutely critical. The immediate focus is on two main tools that give really fast, really vital clues: the 12-lead ECG and those cardiac enzymes, the blood tests we mentioned. The ECG, that tracing of the heart's electrical activity, is step one. Guidelines say it must be done, read, and interpreted within the first 10 minutes of a patient arriving in the emergency department. 10 minutes.
10 minutes. Okay, so the ECG gives that instant electrical snapshot. What are doctors actually seeing on that printout? How do they decipher it so quickly to figure out what's wrong and where?
It's quite fascinating, actually. There's often a typical progression they look for. First, you might see changes in what are called the T waves. Then, crucially for STEMI, those ST segments start to elevate. And later on, if muscle damage has occurred, Q waves can develop, indicating scarred tissue. But it gets even more specific. The ECG is like a map. It can help pinpoint where in the heart the damage is happening, and usually which artery is blocked. So, for instance, if they see ST elevations in the leads labeled V1 through V4, that points strongly to the front wall, the anterior wall, and usually means the left anterior descending artery, the LAD, is involved. If it's just V1 and V2, it's likely the very beginning, the proximal part of the LAD. Changes in leads 1, AVL, V5, and V6 suggest the side wall, the lateral wall, often involving the circumflex artery. If you see changes across a bunch of those leads, AVL, V4, V5, V6, that's anterolateral, pointing maybe to the mid-LAD, the circumflex, or even the big left main artery. Inferior MIs down at the bottom of the heart show up in leads 2, 3, and AVF, and typically involve the right coronary artery, the RCA. And here's a neat diagnostic trick. Posterior MIs on the back wall often cause ST depressions in leads V1 and V2. It's like looking at the ST elevation from the opposite side so it appears inverted. Sometimes they'll even do a special right-sided ECG. If they see even a small ST elevation, just 1 millimeter in lead V4R on that right side, that's highly specific for a right ventricular MI. So yeah, tiny details, huge clues.
That's incredible, mapping the problem that fast. Okay, beyond the electricity, what about those cardiac enzymes, the blood tests? How do they fit into confirming the diagnosis?
Right, the enzymes, or biomarkers, they're absolutely essential too. Troponin I and troponin T are the go-to markers now. Think of them as specific proteins that normally live inside heart muscle cells. When those cells get injured or die because they're starved of oxygen, troponin leaks out into the bloodstream. So finding elevated troponin levels is a very specific sign of heart muscle damage, what we call myocardial necrosis. They usually start to rise in the blood about 4 to 6 hours after the heart attack begins, and they can stay elevated for quite a while, maybe 7 to 10 days. There's another enzyme, CKMB. It also rises in that 4 to 6 hour window, but it clears out of the blood much faster, usually within 3 or 4 days. That shorter lifespan makes it particularly useful if doctors suspect someone might be having a second heart attack or reinfarction shortly after the first one. And standard practice is usually to draw blood for these markers 3 times, typically about 8 hours apart. This helps track the rise and fall, giving a clearer picture. But there's a caveat. Troponin can sometimes be elevated for other reasons, not just a heart attack. Things like severe kidney failure, advanced heart failure, a big blood clot in the lungs, a PE, or even a stroke can sometimes cause a rise. So doctors always interpret these results in context, looking at the whole picture, the symptoms, the ECG, everything.
Okay, so the diagnosis comes together quickly from the ECG, the symptoms, the biomarkers. Time is muscle, as they say. What happens next? What's the immediate, all-hands-on-deck approach to actually managing ACS and saving that heart muscle? It sounds intense.
It is intense, absolutely. And the training focuses on making these complex decisions very rapidly. Now, the initial management for all types of ACS shares some common ground, but then there are really critical differences, especially when it comes to reperfusion, getting that blocked artery open again. So, for pretty much anyone suspected of ACS, the first steps usually involve giving aspirin, a good dose, often 325 milligrams, and importantly, they'll have the patient chew it. That helps it get absorbed faster.
Chew the aspirin, okay.
Yep. Then there's nitroglycerin, usually a small tablet under the tongue or a spray. They might give it every 5 minutes, up to 3 doses if the chest pain isn't going away, or if the patient has high blood pressure or signs of heart failure. And this is a big, but you absolutely avoid nitro if there are signs the heart's struggling, like in a right ventricular MI, or if the patient has recently taken certain drugs like Viagra or Cialis. That combination can cause a catastrophic drop in blood pressure. If the pain is still bad, they might start an IV drip of nitroglycerin.
Makes sense.
Oxygen, only if their levels are actually low. We used to give it routinely, but now it's just if needed to keep saturation above 90%. Morphine might be considered for severe pain that doesn't respond to the nitro. A high-intensity statin drug like atorvastatin is started early. It helps stabilize plaque and lower cholesterol long-term. And then come the heavy-duty blood thinners. Patients get what's called dual antiplatelet therapy. That's aspirin plus another powerful antiplatelet drug like clopidogrel or ticagrelor. And on top of that, they get anticoagulant therapy, heparin, or similar drugs to stop new clots forming or existing ones getting bigger.
Okay, that's the initial cocktail. But you mentioned key distinctions, especially about reperfusion. How does the game plan change dramatically for a STEMI, that total blockage, compared to unstable angina or NSTEMI?
This is probably the most crucial difference in management. For a STEMI, where that artery is completely blocked, getting blood flow restored immediately is everything. That's reperfusion therapy, and it's the absolute cornerstone of STEMI treatment. The best way, the preferred method, is percutaneous coronary intervention PCI. That's the angioplasty and stent procedure you hear about, where a cardiologist threads a catheter up to the heart and physically opens the artery. The clock is ticking here. Ideally, PCI should happen within 90 minutes of the patient hitting the door of a hospital that can do PCI. If they need to be transferred to one, the goal is within 120 minutes. And generally, it needs to be done within 12 hours of when the chest pain first started.
90 minutes, that's fast.
Extremely fast. Now, if PCI isn't available quickly enough, maybe the hospital isn't equipped or transfer takes too long, then the alternative is clot-busting drugs. Fibrinolytics, like Alteplase. These are powerful medications given intravenously to dissolve the clot. Again, time is critical. Fibrinolytics should ideally be given within 30 minutes of arriving at the ED and also within that 12-hour window from symptom onset.
Okay, so STEMI, open the artery, fast. What about UA or NSTEMI?
Right. For unstable angina or NSTEMI, the situation is different. Here, those powerful clot-busting drugs, the fibrinolytics, they have not been shown to help and might even cause harm, so they were not used. Instead, the focus is on that initial strong medical management. We talked about the aspirin, the other antiplatelets, the anticoagulants, statins, etc. Then doctors use risk scoring systems, things like the TAME or GRACE score, to assess how high risk the patient is. Based on that risk assessment, they decide if and when the patient needs an invasive approach, like coronary angiography, looking at the arteries with dye, and potentially PCI. This might happen relatively early, maybe within 24 hours for higher risk patients, or might be delayed or managed medically for lower risk ones. And thinking longer term after a STEMI especially, medications like ACE inhibitors are really important. They help prevent the heart from changing shape negatively, what we call remodeling, and they reduce mortality. Beta blockers are also standard long-term therapy to reduce the heart's workload and prevent dangerous rhythms. It's incredibly precise, tailored medicine.
It really is. So many precise, time-sensitive steps. It sounds like you have these clear pathways, but you also mentioned sometimes the standard rules have to bend. Are there specific patient situations where treatment needs crucial changes? Why are those variations so vital?
That's a great point, and yes, understanding these variations is absolutely key because the underlying physiology can be quite different. Take a right ventricular MI, for example. This often happens along with an inferior or posterior MI. These patients can present differently. They might have a slow heart rate, bradycardia, or certain types of heart block. Why? Because the right coronary artery, which is usually the culprit in these MIs, also supplies blood to the heart's natural pacemaker, the AV node, in most people. They might also have a specific heart sound, an S4 gallop, and they're often prone to low blood pressure hypotension.
Is there a classic set of signs doctors look for to spot that RVMI quickly?
There is, yeah. There's a classic triad. First, increased jugular venous distension, JVD, you can actually see the neck veins bulging. Second, their lungs sound clear when the doctor listens no fluid backup, like in left-sided failure. And third, a positive Kussmaul sign. That's where the neck veins actually bulge more when the patient breathes in, which is the opposite of normal.
Okay, JVD, clear lungs, Kussmaul sign.
Exactly. And knowing it's an RVMI changes management significantly. These hearts are very preload dependent. Preload is basically the amount of blood filling the heart right before it contracts. An injured right ventricle needs enough volume coming back to it to pump effectively. So the cornerstone of treatment is actually giving IV fluids like normal saline. This increases the preload and helps boost their cardiac output and blood pressure. Conversely, you have to be extremely careful with drugs that reduce preload. That includes IV nitroglycerin, morphine, beta blockers, and calcium channel blockers. Giving those standard drugs too readily can cause their blood pressure to plummet or make the heart pump even less effectively.
Wow, so giving fluids instead of immediately reaching for nitro. Okay. What about something like a cocaine-induced heart attack? That sounds like it would pose completely different challenges, maybe even needing opposite treatments.
It absolutely does, and it's a critical scenario to recognize. The mechanism is totally different. Cocaine jacks up the sympathetic nervous system and hits alpha-1 receptors hard, causing the coronary arteries themselves to spasm, to clamp down severely. On top of that, cocaine makes blood more likely to clot and massively increases the heart's oxygen demand because it speeds up the heart rate and cranks up blood pressure. Symptom-wise, though, it can look just like any other heart attack: chest pain, anxiety, shortness of breath.
So how do you treat that differently?
The treatment flips some standard rules. The drugs of choice here are calcium channel blockers and nitrates. Why? Because they directly relax smooth muscle and help reverse that coronary artery vasospasm. That's the primary problem you need to fix. Benzodiazepines like lorazepam or diazepam are also really important early on. They help calm the patient, reduce that sympathetic overdrive, and can help control the agitation and high blood pressure. Now here's the major don't. Avoid non-selective beta blockers like propranolol. If you block the beta receptors without also blocking the alpha-1 receptors, you get unopposed alpha vasoconstriction. The blood vessels clamp down even harder, potentially making the ischemia much, much worse. It's a dangerous situation.
So no standard beta blockers.
Right. If you absolutely feel a beta blocker is needed, you'd have to use one that also blocks alpha receptors, like labetalol or carvedilol. And you still give aspirin and heparin because you don't know for sure if there isn't underlying atherosclerotic plaque involved as well until you can investigate further.
Okay, that's a huge difference. And then you mentioned coronary vasospastic disorders like Prinzmetal angina. How are they different again, especially since exercise isn't the trigger?
Yeah, Prinzmetal or variant angina is another distinct category. The triggers here are often things like exposure to cold weather, certain vasoconstricting drugs, think decongestants like pseudoephedrine, some migraine meds like sumatriptan, even things like cocaine, marijuana, or alcohol withdrawal. Hyperventilating can even trigger it. But as you said, interestingly, physical exertion usually doesn't bring on the episodes, which is a key difference from typical stable angina.
Who tends to get this?
It tends to affect younger patients, often under 50, and it's actually more common in women. Smoking is a big risk factor. People with other vasospastic conditions like Raynaud's phenomenon or migraines are also more susceptible. Sometimes even low magnesium levels are implicated. The classic symptom is chest pain that occurs primarily at rest. It often happens during the night or early morning hours. The episodes usually last maybe 5 to 15 minutes. Diagnosis often involves catching it in the act, basically. Seeing transient ST elevations on the ECG during an episode, which then resolve completely when the pain goes away, often after giving nitroglycerin or calcium channel blockers. If they do an angiogram, the arteries usually look clear of major blockages, but doctors can sometimes induce the spasm during the procedure to confirm the
And the
diagnosis.
treatment.
Management is focused on preventing the spasms. Quitting smoking is crucial if they smoke. The absolute mainstay of treatment is calcium channel blockers, drugs like diltiazem, amlodipine. They relax the blood vessels and prevent the constriction. Long-acting versions taken at night are often recommended. Short-acting nitroglycerin under the tongue is used to treat acute episodes when they happen. Long-acting nitrates are sometimes used, but they're usually second line because people can develop tolerance. And here's another critical avoid. Beta blockers, especially the non-selective ones, should generally be avoided. Like with cocaine, they can potentially lead to unopposed alpha-mediated vasoconstriction and actually worsen the vasospasm. Even aspirin is used cautiously, as high doses can sometimes inhibit natural vasodilators.
So many crucial details and exceptions. Given all this complexity, are there any final sort of overarching medication cautions that apply widely, or maybe to specific groups that our listeners should just tuck away?
Yes, definitely a few key ones to remember. First, NSAIDs, that's non-steroidal anti-inflammatory drugs, like ibuprofen or naproxen. All of them, except aspirin, should be stopped immediately if someone might be having ACS. They've been linked to increased risk of cardiovascular events in this setting. We mentioned the contraindications for nitrates.
Mm.
Definitely avoid if blood pressure is very low, systolic under 90, if there's a known right ventricular MI, or if the patient recently took phosphodiesterase 5 inhibitors like Viagra.
Right.
Beta blockers, while super useful generally, have a list of contraindications too. Doctors avoid them in decompensated heart failure, very slow heart rates under 50, certain heart blocks, low blood pressure, systolic under 100, severe asthma or COPD if the patient is in shock, and as we hammered home, usually in cocaine-induced MI. And lastly, ACE inhibitors, another common heart medication, are contraindicated if someone has severe hypotension, kidney failure, or is pregnant. So yes, while there are protocols, individual patient factors and specific scenarios always require careful consideration. It's all about precision medicine.
Wow. That was truly an incredibly detailed journey through acute coronary syndrome. We've covered so much ground, from understanding the subtle but critical differences between unstable angina and STEMI to the lightning-fast diagnostic workup with ECGs and biomarkers, the really precise and time-sensitive treatment plans, and crucially, how treatment has to be adapted for unique situations like RV infarcts or cocaine use.
It really was quite a deep dive. We aim to show ACS isn't just one thing, but this vital spectrum. We saw how crucial prompt diagnosis is using those key tools, and we explored those very specific rapid management strategies, especially reperfusion for SNEMI, and highlighted why those special considerations are so incredibly important for patient outcomes.
And remember, all of this comes directly from detailed medical sources and clinical guidelines. So hopefully this deep dive has given you, our listener, a much richer understanding than you'd get from just a news clip. It empowers you to better grasp these life-threatening conditions and appreciate the real precision involved in modern cardiac care.
Absolutely, and maybe it leaves you with a thought. Considering the incredible speed and precision needed for ACS and all these unique patient factors we discussed, what might be the next big leap in emergency heart care? Could it be even more personalized diagnostics, maybe using AI? Or perhaps more advanced treatments that can start even before someone gets to the hospital? It's definitely something to ponder.